contribution to the bilingual education in our schools. Gracias and thank you.
Good morning, Boquete. Good morning, Chiriquí. Welcome to Radio Chiriquí 103.3. This is Talking with Your Doctor, and I'm Dr. Shannon Tour. It is a beautiful day today, a little bit overcast now. Hopefully it'll be nice and warm and sunny like it was yesterday. That was a beautiful day yesterday with a little bit of rain. I'm here with my guests. I have here Jessica Bell. She is the owner of the physical therapy clinic in Boquete, and not only that, but she's also a physical therapist, a very good one, I might add. And I'm also here with Dr. William Tour. Hi, Doctor.
Good morning, Shannon.
I hope you're doing well over there. You're right now in Florida, correct?
Yes, we're in Palm Beach Gardens.
And how's the weather out there today?
Hot, humid, but sunny.
It sounds great. It sounds great. So, just to give a little bit about your background, you were born in Montreal, and you spent part of your childhood there in Canada, correct?
That's right.
And you went to medical school at the University of Toronto, and following your medical education, you did an internship and residency in pediatrics at Long Island Jewish in New York, correct?
I did that.
Okay, and it's a long story, but you ended up joining the Army. While you were in the Army, you actually decided to further your education, and you did a fellowship in allergy and immunology at Walter Reed in Washington, D.C.
Yes, I did, Doctor.
And you are certified both in, board certified, I should say, in both pediatrics as well as allergy immunology. And you're also a fellow of the American Academy of Allergy, Asthma, and Immunology, as well as a fellow of the American College of Allergy, Asthma, and Immunology at the European Academy of Clinical Immunology, correct?
That's right, yes.
Okay. So you also practiced here in Panama when the U.S. military, when the U.S. Army was here.
That's right. I was lucky enough to get down there and spend about 8 years in Panama. And I was in the city at Gorgas Hospital.
Which is now the Oncological Hospital.
Correct.
And you started there as the deputy commander, and then you finished, off your final years of your military career as the commander of that hospital, as well as being the command surgeon for the Southern Command.
That's correct. Yes.
So you have quite a bit of experience of how the medical system works here in Panama as well as in Central and South America, correct?
Well, that's correct. We interacted with most of the hospitals in Panama City, and then later, as the command surgeon, my position was to visit most of the Central and South America and certify them for the United States embassies in each of the countries for the military groups.
Wow, so you've had a very, very interesting career path, you could say.
Well, it's been great fun, and now as a civilian, it continues to be very interesting and a lot of fun.
Okay, so right now you're working as an allergist immunologist there in Palm Beach Gardens, Florida. You specialize in obstructive lung diseases such as asthma, as well as allergies and other conditions, immunological conditions, let's put it that way. And today you're going to speak a little bit with us about asthma and its treatments.
That would be fine, correct.
Okay, first off, let's talk a little bit about asthma itself. what exactly are we talking about when we talk about asthma?
Well, asthma is a very, very common condition, and we think of it as an inflammatory condition. And the main elements would be bronchospasm, that is narrowing of the airways, and mucus production.
Okay.
But fortunately, we've come a long way in the treatment of asthma.
Right, and I, as an asthma sufferer, have been kind of exposed to all those treatments since I was a little girl growing up. I kind of went through the gamut of all the different treatments available at the time up till now.
Right, we're very fortunate, and there's been the treatment of asthma has come along in leaps and bounds. And you know, it's interesting. Asthma can begin at any. It can begin in a little baby, or now there's an entity recognized as adult onset asthma that occurs often in 50s and 60s in people that have never had asthma before.
And how do we diagnose it in a baby? I mean, I know that babies can also suffer from the respiratory syncytial virus, which is kind of mimics asthma. How do we say finally that the baby or the young child possibly is asthmatic?
Well, you know, it's interesting you ask that.
¿Qué pasa si alguien me
Sometimes
llama?
it's difficult. Often respiratory syncytial
Debería,
virus sets the stage
aparece el anuncio ya,
for
pero no
asthma.
bloquea la llamada.
But the presentation of asthma in little
No se
children
bloquea esta comunicación.
is sometimes it's easy to make the diagnosis, but we'll see babies or small children that have been referred to us by pediatricians who've gone for a year or more with intermittent symptoms that most likely were asthma but weren't recognized as asthma. Because often in children, it's not a wheeze. Do you know what a wheeze is, I guess, having suffered asthma?
Right. It kind of sounds like you have a cat living in your chest.
No debería.
But often, small children will have just a cough, and we call that cough variant asthma. Some will wheeze. So if a mom comes in and says, well, I don't know, my child has had bronchitis a couple of times, but doctor, I really don't know if he or she has asthma. And we'll ask a few things, because often it'll occur just when the child has a cold. And the pediatrician might or might not have already given them one of the major treatments in children of asthma, that is albuterol or salbutamol, and that's nebulized in a machine. Or ask other things. Well, what about when the baby cries or laughs hysterically, or moves around? Is there a cough afterwards? Well, now yes. Now we don't have much cold air here. You, I guess, have cooler air where you are.
Especially at night.
Okay. Well, that would be another thing. So, signs of airway reactivity. Now, if they've given the child albuterol in the nebulizer, and the child responds, the only thing that medicine does is open up a lung that has a little bit of constriction. So it kind of makes the diagnosis for you. It's difficult to measure the function of the lung in little babies. It can be done in university centers, but usually by the time a child is 5 or 6, most of us have computerized equipment, and they'll blow into the machine, and it'll tell us, okay, well, little George has some airflow limitation, or the volume down, and so forth, and then we'll nebulize them with albuterol and do it again, and we're looking for a change of maybe 15, reversible to some extent.
Correct. So, talking a little bit more about this, as we know, young kids are not going to cooperate for that. So when we look at really young kids that can't cooperate for that kind of a test, what we're looking for in young babies and really young children is the nasal flare when they breathe, retraction, muscular retraction between the ribs, underneath the collarbone, and also the movement of the stomach. You can notice how hard the child is trying to breathe with those types of signs, since the child can't really talk and tell you what's going on.
Well, that's a very good point. Do you see many children with asthma where you are practicing now?
We see a lot of children with respiratory problems that we might consider a diagnosis of asthma, especially when it's repeatedly, the child is repeatedly coming in with the same symptoms, with wheezing, with the difficulty breathing, especially if they get a cold or some other virus. We'll start to suspect, especially if they respond to treatment with bronchodilators, such as a Ventolin inhaler or salbutamol or albuterol inhaler.
I see. Well, it's interesting. So, as I mentioned, and I'm sure you see the same thing, it can happen at any age. And sometimes when children have asthma, it fades away as they approach adolescence, which is wonderful when that happens.
And is asthma a hereditary condition? Can we predict who might become asthmatic?
Well, there are some genetic hints, you might say. There are closely or loosely linked gene pairs that would maybe give you the propensity to have hay fever, that is, runny nose and sneezing and so forth, allergies, eczema, and that's a rash sometimes that children have, and asthma. So you might say the genotype will go through families. We see that a whole lot. But the phenotype, that is what you see, sometimes we'll see people that have had eczema as a child, and sometimes it persists into adulthood. And they'll say, well, I've never had asthma, but my nose runs and I'm always sneezing. But my brother, on the other hand, and my dad have asthma. So it passes through generations. We certainly see these, what we'd call linear genetic relationships. But the penetrance, that is the expression, is very variable. So you could say that, right.
But a parent or a grandparent wouldn't necessarily have to have asthma. They could also just have severe allergies, right?
Or nothing at all.
Or nothing at all.
Exactly. And we'll certainly see people, and they'll say, no one in my family has ever had asthma that I'm aware of. And they might not know if their great-grandma had hay fever. They might not know. So we'll see plenty of people that way, too.
Correct.
And,
so really, it's not very easy to predict who will get asthma, who will get better as they get older, get into adolescence, and who might develop it as an adult or later in life.
No, very often you can't predict. They've done tons of studies. In the old days, perhaps going back 60 or 70 years, it wasn't called asthma or wasn't recognized, but maybe as bronchitis or winter cough, something like that. But in any event, we kind of then, when it's existent, we categorize it. So there's mild asthma, and we see plenty of people that it only happens, we say mild intermittent. It happens when they run, if they're athletes. And we would see that in the Army. Everyone, we all had to do PT and run every day. And some soldiers would have a little trouble only while running. But so they pre-treat, and this is how we do it. That many athletes have asthma, mild, pre-treat with salbutamol, maybe 30 minutes before. I'm sure you're familiar with that.
Oh, well, yeah. Definitely being an asthma sufferer myself. Unfortunately, mine isn't only when I exercise. It's what you would call severe, but very well controlled at this moment. But as you said, there are different categories, and the treatment that an asthmatic might receive depends on how we categorize their particular asthma symptoms.
Well, that's right, yes. And the fortunate thing is we have so many great treatments available now.
And would you recommend that a mild case of asthma use a control inhaler, an inhaler to prevent symptoms, or do you just recommend that in more frequent asthma symptom cases, a little bit more severe, or do you just have to take it on a person-by-person basis?
Well, it is a person-by-person basis. I'd say if there were 1 or 2 episodes a week at most that the person would need their inhaler, we would go with that. However, if they start waking up at night or they notice some of the more subtle signs, the nuanced signs, well, I do cough every time I laugh, that kind of thing, mild, but enough to be noticeable. You see, then we'd say, well, what about a maintenance medication? So we think of, with our Spanish-speaking patients, Rescate, and that would be the salbutamol.
Rescue inhaler, the salbutamol or albuterol.
Yeah, and then maintenance. And maintenance would be the mildest that you can go with. And the American Academy of Physicians, actually NIH, put out a monograph about 2 years ago on the approach to the treatment of asthma. And it was over 700 pages, and I don't think anyone read the whole thing, but it's largely intuitive. You would say, well, that's what we should do.
Right.
So we would start with a controller medication if you were having symptoms more than a couple of times a week.
Right.
Or that really needed to excel. There are all kinds of possibilities. And just as you said, it's very individualized.
So an athlete, you might consider, yes, they should be on a preventive medication, a control medication, so that they can get their peak performance. Whereas someone that just has mild symptoms once in a while that is resolved with a rescue inhaler may not necessarily be a candidate to use a preventative or maintenance inhaler.
Well, that's right. That's how we look at it too. Exactly.
Okay. And now when we're talking about a maintenance or a preventive inhaler, we usually are talking about a corticosteroid, a steroid inhaler. And those obviously have been in the news a lot lately because of some studies with COVID that it helps control some of the inflammation that COVID produces in the lungs.
Yeah, well, that's I might say, and I think you have seen the data too, that people with asthma aren't necessarily very much more likely to get COVID.
Correct. They're not predisposed necessarily to get COVID.
If the index of 1 would be someone with nothing, I think it was 1.17. So I think it's very important that if you do have it and you might be around someone and you pick up COVID, then to have the asthma as well controlled as possible. But just as you said, sure, now they're looking at budesonide, inhaled budesonide, and then inject oral steroids if the people get a little sicker.
Right, because of the inflammation in the lungs. What the corticosteroid does is it lowers the inflammation. And as we know, the asthma is an inflammatory disease, and COVID has some inflammatory properties.
Well, so with asthma then, as you said, we often go, there are 2 major groups, I guess, of maintenance at that level, at a low level of need. One would be, do you have Montelukast there?
Yes, we do, the singular Montelukast.
Well, that, as you know, is not an antihistamine, it's a leukotriene antagonist.
Correct.
What are leukotrienes? Leukotrienes are made by our white blood cells, and often they're found to be elevated in asthma. And so that they're available for children and they're available for adults. And it may help. Certainly when we look at the cytokine storm, they're akin to that. We're looking at interleukin-6, for example, the cytokine storm. So they can be effective. However, in my own experience, I've found, as you said, the inhaled steroids are quite a bit more effective. There are exceptions. I suppose if a person makes a lot of leukotriene, then it might be the singular, the Montelukast might do very well.
Right.
kind of binary. Have you found that it either works or it doesn't work at all? There's not much of a gray zone in between.
Right. There's some people that just stop taking it. They don't adhere to the therapy because they don't see any results. We do know that it doesn't work from one day to the next day. It has to be sustained over a period of time. Some people refer to having an immediate effect, and some people do not. It's really variable.
How do you approach it with the inhaled steroids? What would be your criteria?
I usually look at somebody that is probably a mild to persistent case, not too well controlled with just a rescue inhaler, that suffers at least symptoms for 2-3 days a week, once or twice a day. Those are the kinds of things I would look at. Or somebody that suffers from allergies and sinusitis that has frequent symptoms. That's another person I would probably put on a steroid inhaler, maintenance inhaler, as well as the control inhaler. I mean, the rescue inhaler, I'm sorry.
And are those very widely used in Panama? You know, because when I was there, of course, being in the federal system, the military system, we didn't, you know, we used American medication. I know they exist in Panama. Are they widely used?
They're widely used for asthma. We use them in patients that have pneumonia and that kind of thing as a temporary thing. Obviously, if we're talking about a control inhaler to control the inflammation in the lungs from a condition such as asthma or having pneumonia, there's people that have listened to the news, have listened about budesonide, have listened about the studies with budesonide with COVID, for example, and they believe if they are taking it as a preventive therapy, although they're not asthmatic and don't have any other reason to take it, that it will prevent them from getting symptoms of COVID if they are ever to get infected. It doesn't really work that way, unfortunately.
We've had a lot of patients who want to. We prefer to keep our stocks available for people that really would need it. But, you know, mentioning that, the budesonide, that's usually the next thing that we use in babies or small children. The parents will say, well, I have to keep using the nebulizer twice or 3 times a day in my 2-year-old because he or she coughs all night. So the pediatricians will add Pulmicort, which would be the brand of budesonide, as you say, and then nebulize it twice a day. I guess you do the same thing. And then, amazingly, the cough goes away, and they don't need their albuterol often.
Right. And also, and I'm sure you've noticed this in your practice, a nebulized medication, in the case of children, is a lot of times necessary because they don't have the coordination to use an inhaler until they get a little bit older. But in an adult, we have found, at least in my practice, I've found that the inhaler is just as effective as using a nebulizer.
Right. Yeah, well, there are a lot of studies that show that. Although, well, I don't know about you. I still have patients that say, well, that's what they say, but if I really need it, I want my machine if my symptoms.
That is actually, I have had that myself in my own struggle with asthma. I have noticed that in certain conditions, certain times, that I prefer using the nebulizer to get the medication deep down into the lungs when I'm having a lot of shortness of breath and I just cannot get the medication into the lungs well enough.
And, you know, speaking of that, the inhalation technique is very important, don't you think? We have a new product that came out. It's albuterol, and it's called DigiClick. And you have an app, and it hooks up. So you can put the app on your phone or the parent's phone, and it'll tell you how many times the person has used their rescue inhaler, and whether the technique was correct or not. And I think that might be useful in the future.
Right, and what we do here, where things are pretty expensive, especially for the local families, for their children or for themselves that cannot get the technique down for the inhaler, We do have the spacers available, which is an aero chamber, which collects the medicine after you puff it, and then you can breathe it in, and you get the maximum dose of the medication for those people that have trouble timing the puff with the inhalation.
That's a great idea.
But here, the aero chambers are very expensive. So what we tell patients, the parents of patients, is that they can use a paper towel roll, a toilet paper roll, and it will work similar to an aero chamber, not perfectly, but it will help.
Well, that's a great idea. You know, the aero chambers are extremely expensive here too, and I'm not sure why. Well, then, Doctor, what we do next is sometimes that's just not enough, right? The inhaled steroid.
That's correct.
It helps, but not quite enough. So we have then a combined agent, and I'm not sure if it's the brands that you have there, but we've got Advair, we've got Symbicort, we've got Dulera. We have 5 altogether, basically. And they're a long-acting bronchodilator. 3 of them will last 12 hours. They're like albuterol, but it lasts 12 hours, so you do it twice a day, plus the inhaled steroid. Are they widely used in your practice?
We do use them a lot. We don't only use them for asthma, we also use them for COPD. It's a great help for those patients that are having trouble controlling with just a bronchodilator or with just other medications to help relieve the sensation of not being able to get enough air. The long-acting ones that are just once a day are extremely expensive here, so we don't have too many patients on them. But the twice-a-day ones, such as Symbicort and that kind of thing, we do use it, and they work very well for most people to control the symptoms of their asthma. And as we were talking earlier, it's not for everyone. We use it in the more symptomatic cases that have frequent symptoms of badly controlled asthma.
Right, well, exactly like what we do. And then sometimes even that's not enough for day-to-day use. And I don't know if you use it there. It's called Teotropinium Bromide. It's an additional one you add to those 2 medications.
Also known as Atrovent.
Okay.
Mm-hmm. Yeah, we do use that, and it does help also with people that have a lot of secretions in their lungs.
Right, because it is an anticholinergic, isn't it?
Mm-hmm. And it has less cardiac effects, produces less tachycardia, less palpitations, chest palpitations, and a lot of patients that can't tolerate using albuterol or salbutamol for their control.
Well, what are your thoughts about steroids? Do you have a lot of patients? I know we have some that periodically nothing seems to work, but to keep them out of the hospital, especially during what's happening here, especially here, we'll use oral steroids, and they can get you through the rough spots frequently.
We do use oral steroids here, especially in very symptomatic cases of asthma, or if they have a cold and they just cannot get relief from their inhaled medications. We will add on top of that an oral cortisone, which we'll do a short burst, maybe 5 to 7 days short burst of the steroid to get them past that rough spot.
Well, it's like exactly like we have. And I'll just briefly mention, I'm not sure if they're available yet in Panama, but I would imagine they will be. The biologics, the monoclonal antibodies, things like Xolair, which is a shot that you get maybe once or twice a month. And it goes to the root, the molecular root of the problem. And we have others that will attack the white blood cell called eosinophil, Senra, and one, the IL-4 and 13, the interleukin. Are they available, or do you know if they're going to be available in Panama?
I think the day that we have Dr. Marco Lopez on the air, maybe we should invite the two of you together to speak, and he would know a lot more about if that is available than I would.
Okay, that'd be fun to for us to speak. He's certainly a great doc, isn't he?
He's excellent. He's also board certified. He did his studies in the States, and he has agreed to come on the show one of these days, so maybe we can set it up so the two of you can speak about the therapies available here in Panama as well as where you are, and if there's any chance that we'll get some of these therapies here. And of course we have some therapies here that aren't available in your area.
Well, you might have some that we don't have too, you know.
Exactly.
My goal is yours the same, is really just to have the best possible lifestyle with asthma interfering as little as possible and allowing people to do what they want to do. Push it past the limits that they're very used to. You know, because we see a lot of couch potatoes. They say, no, it's okay, it's not too bad, but they never do anything. You know, they just kind of sit around watching.
And they don't realize how badly they're actually feeling until you start to make them better, and then they notice.
That's exactly right. And they're so happy, and I don't know about you, you get such joy out of seeing how you can, how these people can improve their lives tremendously with what's available, because we have so much available right now.
And when I get my tough cases, the first person I run to do a consult with is you. So my patients that I've treated can thank you for your input on some of their cases.
Well, I understand though that you were saying that you have some great pulmonary docs there in David, right?
We do, but as I said, the general medicine docs at this moment are the ones that are handling everything. We are the specialists at the moment for, you know, all of the cases that come up until we can get them in with a specialist. The specialists are doing the rotations through the public hospitals. They don't just work at the private, so they're required to do shifts at the public hospitals.
I see. Well, it doesn't. You don't have to be a specialist to do this. You know, it's just getting used to working with this particular with asthma, and certainly a general physician can do just fine with their patients that have asthma. I'm sure.
Oh yeah, we learn to control it pretty well, and especially those of us that also suffer from the same thing. Our time is just about up, and I just wanted to ask you just one last thing, and I know we were talking about it last night, especially for people that have underlying conditions like asthma, like other immunosuppressed patients. Do you think it is really important that they wear their mask when they go out in public, when they go into a crowded store? What are your views on masks?
My opinion is incredibly important. I know, I believe the government, your medical, is it Luis Sucre? Is he the new Minister of Health?
The Minister of Health,
Yeah, I understand that they're pretty strict there. I think it's very important. As you know, if you watch American news, we have a lot of rebels, and it's getting us in trouble. There's a huge motorcycle rally, I think, in I'm not sure where, Montana or one of the states up there.
Right.
And 50,000 people are there, and they doubt any of them will wear masks. And they're in a town of 7,000. And they'll be coming from everywhere, some of them bringing it, because we see so many asymptomatic individuals. And they're going to be bringing it back. And I think it's foolhardy not to keep social distancing as much as possible and wear a mask. And I'll tell you, the big problem here now, or the challenge, is every state is different, and the schools, and we've got a lot of worried moms, and more so worried teachers. And the mandate is no, send them back. It's very variable. It depends on caseload and whether it's increasing or not. But we see stuff here. In this county, in Palm Beach County, you must wear a mask if you're in a supermarket and so forth. but it's so important. Yes, I won't belabor the point, but I think that's just common sense, don't you?
Right. I think it is too. And there's a lot of people that point out that the mask isn't effective. It's not 100%. Nothing's 100%. They say if we have to distance 6 feet, then and that works, then why do we need to use a mask? Or if the masks work, why do we have to distance 6 feet? Well, because the masks are not 100%, and neither is distancing yourself 6 feet going to be 100% effective. It takes the combined effort of the community. Everyone around in a crowded area must wear a mask to help prevent the spread of this virus, or any virus, not just this one, but this one is extremely contagious. And that's why they recommend not only distancing, but also each person must have their mask.
Well, I think that's a great idea. And you've heard, if everyone would wear a mask, we'd see a tremendous decline in the projected number of deaths, because we're looking at 300,000 by the end of December if people don't adhere to the masks.
Mm-hmm. And for those that have any doubt, the mask is not going to lower your oxygen saturation while you're wearing it. Doctors wear them all day long and don't seem to have a problem with it. So going to the store for 15 minutes with a mask shouldn't be a problem for most people. If you're that sick where it affects your breathing, then you should probably stay home, correct?
Oh, yes.
Okay, well, Dr. Tour, thank you so much for being on the show today. We really enjoyed it. It was very informative. And I hope that you can come back and talk about something else. I'm sure there's going to be a million questions now about some of the things that you've talked about. And maybe you'd like to come on again and answer some of those questions.
Well, thanks a lot. I appreciate it. Thank you so much. This is a lot of fun. Thanks.
Okay, thanks for being with us. We'll keep listening to the show. We're going to be talking with Jessica now, and she's going to be talking about back injuries and how to prevent them.
Fantastic. Very much.
All right, thanks for being on the show. Have a great day.
You too. Right you are.
All right. Hi, Jessica. Good morning. So, what did you think about Dr. Tour and his advice and his information about asthma?
The advice that he told to us, especially about to use the mask, because people doesn't want to do that, especially here in Boquete.
Exactly. Estuvimos hablando antes con el doctor William Tour. Él es alergólogo, inmunólogo, y nos estaba hablando sobre el asma y su tratamiento. Cada tratamiento es diferente, depende de la persona y su caso específico, de qué medicamentos requiere. También habló de la importancia de utilizar su mascarilla para prevenir contagiarse con el virus o cualquier otro bicho que está ahí en el aire. Ahora estamos aquí con Jessica Bell. Ella es fisioterapeuta aquí en Boquete. Ella nos va a hablar sobre lesiones en la espalda y cómo prevenirlas.
Yeah, good morning everyone. Back pain is one of the most very common consults on doctor office and also for physical therapists. We have some measures that we can take for prevent that kind of injuries, and that's what we're going to talk about today. El dolor de espalda, ya sea espalda alta, espalda baja, es una de las consultas más comunes en las oficinas del doctor, inclusive en fisioterapia, pero existen algunas medidas de prevención que podemos tomar para evitar que tengamos estas dolencias, tanto en espalda baja o alta, y vamos a mencionarlas a continuación. One of the most common reasons of back pain on upper back or lower back, it's because of our posture, the way that you sit on the chair and the way that you take something from the floor. We have a lot of reasons for that. What we can do with that? For example, if you want to take something from the floor, I always say to the patients, try to bend both knees and take something from the floor. But what they told to me, what happened if I don't have enough flexibility in my legs to do that. Well, I say you have to do more physical activity for that. That's why you need to stretch more at home.
Strengthen the legs,
The
strengthen
legs.
And stretch.
Yeah,
Do
not,
stretching
yeah,
exercise.
stretching exercise, not only for the back, for the leg, because remember everything is connected.
Right.
Uno de los tips más importantes para prevenir lesiones o dolores de espalda es cuando se van a agachar, siempre tratar de doblar nuestras rodillas, así vamos a prevenir una lesión de espalda. Algunos pacientes me dicen, no tengo la flexibilidad para doblar mis rodillas y llegar hacia el suelo. Entonces mi recomendación es realizar ejercicio de estiramiento para las piernas, no solamente para la espalda, y así podrán optar por una mejor flexibilidad.
And also, it's probably a good idea to limit the amount of weight that you're lifting, not to lift anything that's too heavy for you. If it's too heavy, then you should get help.
That's true. If you have to take something from the floor, like a box, and if it's too heavy, please ask for help to somebody, so you don't need to do it by yourself, or just be careful with that.
They can also use the carretilla, the I forgot what it's called in English, to help lift and move the box. So
Sure.
that you're doing the work more with your arms and with your legs to move the object.
Sure.
Or as you said, if it's just too heavy or it's too bulky, too big to manage, then you should always do it with help.
Yeah. Si van a levantar algo del suelo que sea muy pesado, es recomendable que le soliciten ayuda a alguna otra persona. Inclusive si lo van a hacer solo y doblar sus rodillas correctamente, es mejor que soliciten ayuda para prevenir una lesión en la espalda.
Correct. So basically, we need to bend from the knees, not use the back to pick up, but
Sure.
use the muscles in your thighs
Yeah.
to help you lift the object along with your arm strength
Yeah.
itself. But you don't want to put your lower back into it.
Yeah,
As we know, these cause different kinds of lesions in the back.
yeah,
It can be only muscular,
yeah.
or you could also inflame a nerve or inflame a disc,
The disc.
cause a hernia even.
That's the most common.
That's the most common
Yeah.
for lifting something incorrectly.
Yeah. Another advice is when you're going to sit, or don't stand for a long time in the same position. Even if just standing, don't stay for a long time. If you're going to be sitting in a shirt, be careful with the shirt. Have to cover all your back, not like this one. Your legs doesn't have to be in the air. Your legs needs to touch the floor.
Touch the floor,
Yeah.
flat on the floor.
Yeah,
Okay.
because all that kind of posture can make a injury or a back pain, even a pain on your legs.
Right. Sometimes we have something called sciatica, and that
Yeah.
comes down the back through the
Yeah.
hip and down into the leg.
And the principal reason of sciatic is the posture. Yeah, that's the main reason for that.
And we also know that sitting on your tailbone, sitting on your hips here, that's when you have the most pressure
Yeah.
put on your lower back.
Yeah, yeah.
So those people that already suffer from back injuries or back pain, they would be advised to stand up frequently
Yeah, yeah,
and stretch and change positions.
yeah, yeah.
Do our shoes have anything to do with back pain?
Yeah, shoes are very important, especially for the woman who use a lot of heels. That changes all the posture of your body, and that will be reflecting on your lower back. And we have a lot of patients with lower back pain causing because wearing heels. Yeah, I use the prepared shoes for walking or hiking. We talk about that.
We talked about it one day.
Yeah.
With cushion and a lot of support around
Yeah,
the foot.
yeah.
What if I had a knee injury once or a hip injury once, and it's starting to get better, but all of a sudden I feel my back is hurting all of a sudden? Does that have anything to do? Could it have anything to do with my knee or my hip
Sure.
injury?
If you have an injury and your ankle, and your knee, and your hip, always your body will be affected because your body adopted different posture for prevent the pain of your other injury. You know what I mean? So that's why we have back pain.
So you kind of compensate. Your
That's
body's
right.
compensating.
Yeah.
So it could even, not necessarily my back, it could affect my other knee,
Yeah,
my
yeah.
other my other
Another
ankle,
joint,
the
yeah.
other joint on the opposite side of my body.
Yeah, that's where the people came from the therapy. We guide these patients about to take care about their back, even if they just have a little injury. Yeah.
So your job is to not only help get rid of the pain and to strengthen the core muscles and the leg muscles, but it's also to educate the patient in the correct manner, the correct posture,
Yeah.
the correct manner to pick up an object, not to do quick, rough movements, especially if you're carrying something heavy.
One of our main reasons for physical therapists to be is prevention. We have to prevent to the patients every kind of injuries or every kind of disease, and this is one of the most important for us, how to prevent the back injury. Another suggestion is when people is sleeping, try to use a pillow under your abdomen, so that make you a good posture when you are sleeping.
Oh, okay.
Yeah, we
Okay.
try to say to the patient, don't sleep on your back because that make pressure to the discs, to the nerve, and that can make an injury. But if the people like to sleep on face down, that's a main advice for that. Use a pillow under your abdomen.
And usually back pain is really difficult to get rid of
Yeah.
because of the amount of use that we get from our lower back, our middle back, our upper back
Yeah.
as part of our core, so we use it for everything.
Yeah.
So once you get an injury, it's really hard to get rid of the pain, to fix the injury.
Yeah.
When medications fail, or in addition to medications, I like to send my patients to a physical therapist.
Sure.
Some people say, well, what's the physical therapist going to do? They're going to put ice and heat. I can do that at home. No, it's a whole lot more besides the education, which I can't do all the education. We don't have time in our practice, unfortunately, to be able to give all the tips and all the instructions and all the prevention measures. That's when it's beneficial, especially when you're just taking too much medication.
Yeah.
We can give steroids for those difficult cases, but they're not recommended. They can do harm over time to the body, and they can weaken the bones and weaken the ligaments.
Yeah.
So in these cases, it is a wonderful help to have a tool like a good physical therapist to work out the injury, to reduce the inflammation, to strengthen the core muscles, and to give tips on preventive measures.
Yeah, the education is the most important for us. We always say to the patient, you can do some therapies here with us. We will show you how to do it or what to do at home, especially the stretch of the back, because it's different stretch for every patient. And then you can continue at your home. It's not necessary to come often here, but you need somebody to tell you
what to do.
Yeah.
Okay. And let's say, okay, I'm your patient. I went through some physical therapy with you. I got so much better. You said, okay, I don't need to see you anymore. Continue to do your exercises as you would normally. Use these preventions to avoid getting another injury. And a couple of months down the line, I wake up and I just got the worst pains in my back again, and that kind of thing. Do you recommend, as soon as your patients start to feel that again, to come and let you know that they're having pain again? What should they do? Is that what you tell your patients, if they have pain later on, that they should get a hold of you again?
Yeah, well, if the pains come back, we need to be sure if it's the same reason or if it's another reason. So our first advice is to go to the doctor, like Dr. Shannon, to do another test to see what is going on. Maybe it can be a muscle injury or these injuries. We're not sure.
Correct. We don't know that it's the same injury. The pain might be in the same place. It might be in a different place. But we don't know it's the same injury.
Yeah.
And in that case, if there's something like a broken bone or something, or a herniated disc, or something is out of alignment, or there's a ligament injury, we could actually do more harm than good than just saying, yeah, come on back and we'll give you some more physical therapy.
Yeah, yeah.
Because you don't necessarily know it's the same type of injury.
Yeah, also with physical therapy, we have to prevent some surgery if it's necessary. We can do 2 or 3 months of physical therapy, depending what kind of injury it is, and we can prevent back surgery.
And that's the ideal thing to
That's
do.
the idea, yeah.
As anybody that's ever had surgery knows, once you're operated on, you never are the same again.
No, even if you need physical therapy after a back surgery, it will be not 100% the same.
Exactly. And of course they recommend before doing a surgery like that to go to a physical therapist and strengthen and prepare for the surgery, unless it's an emergency type surgery,
Sure.
to get prepared so that you can recover more quickly from the surgery. And usually the surgeon recommends physical therapy almost immediately.
Yeah.
Almost immediately, except for in certain conditions. And of course that's always the decision of your treating doctor.
Yeah.
But in most cases, physical therapy is started either same day or next day.
Yeah, that's right. Depending of the diagnosis of the kind of surgery the doctor did. You know what is most important? Usually when the patients came to my consult, they say, I don't know what to do. What I did. I don't know what is the reason of my back pain. I didn't do anything like movement or something. But maybe not. But maybe you are not using the correct shoes, you are doing your posture in the wrong way. It's different reason for that.
Right. You need a trained person to teach you how to do some of the correct the exercises correctly.
Yeah, yeah.
Which exercises you should be doing also.
Yeah.
And if you haven't been to a doctor to see what's going on first, you should go to a doctor first to make a diagnosis before going to a physical therapist.
Yeah.
Physical therapists are trained to recognize injuries, are trained to treat injuries, prevent injuries, but they can't necessarily diagnose you.
Yeah.
They don't have x-ray vision, so they can't see what's going on in your body, unfortunately. Many times I wish I had x-ray vision.
Yeah, me too.
But, so this has all been great information. So let's say a patient wants to see you. Is your clinic open? Are you working?
Yeah, we are open. We are taking appointments. Everything is by appointments. We have our cell phone numbers, and we also we are doing home visits.
Oh, perfect. Yeah. And for those that are afraid to go into your clinic or afraid to have you over, you are taking measures to prevent any infections.
All
correct?
the measures requirement for the MINSA we are taking, also like the clinic and at home.
And you require your patients to wear a mask when they go to the clinic to see you and when they're doing the treatment.
Yeah, they have to do it.
Yes. You wear your mask, they have to wear their mask. Alcohol spray, washing hands.
Yeah.
Now, the phone number where they can make an appointment or send you a WhatsApp to make an appointment?
Okay, it's 62. Okay. Just a sec. 6211.
6211
7011.
7011.
And the other one is just a sec. 6741
6741
8115.
8115.
Yeah.
And it's you and also Licenciada Belkis, correct?
Yeah, we are 2 physical therapists there.
Okay, and both of you are bilingual?
Yeah.
Okay, perfect. That's
It's
excellent.
perfect, but it's enough.
It's enough to get through, just like, you know, patients I'm sure want to speak Spanish with you to practice as well.
They always happy when they see that we can speak English with them.
Now we have one of our most frequent visitors to the show back from Pizzeria Brasileirissimo.
It's hard to say.
Brasileiríssimo, very Brazil.
Very Brazil, and it's located after Banco Nacional in front of the old Banco General Los Estados Plaza, and they are open 7 days a week, 7 días a la semana.
Exacto.
And they're available for both takeout, para llevar, and delivery to your house. And they are open from 11 a.m.
Hasta
until
10 p.m.
10 p.m. for delivery.
Sí, exacto.
And
Take
from
out is at 7.
until 7, 11 a.m. until 7 p.m. They have two websites. One is on Facebook.
Facebook, Pizzeria Brasileiríssimo. Website, Pizzeria Brasileiríssimo. Y nuestra página tiene todo el menú, tiene las fotos. Y puede llamar en 6546-5663.
En inglés.
Sí, es easy.
65
6546-5663. 6546-5663.
And the people can order by WhatsApp. For WhatsApp.
WhatsApp, yes,
Or
WhatsApp.
call.
Or order for it's easy in Google Translation.
It's very easy on Google Translation if you send a message to WhatsApp.
Sí.
And you also send menus by WhatsApp to your clients.
Exacto. Hoy he traído un espaguete a carbonara. Espaguete a carbonara, como hacemos en Brasil.
Oh, wow.
Espaguete carbonara es un espaguete muy rico, hecho con cebollas, bacon, maíz nuevo y jamón. Y es muy rico, y también un poquito de parmesano. Es muy rico.
Oh, wow. And bacon? Is that bacon?
Bacon,
Smells good.
corn,
So this
ham, y onions.
it's a very great looking pasta. It's got ham, it's got bacon, it's got corn, it's got onions, it's got some Parmesan cheese. And it's and today, I wish you guys could see this and smell it too. It's really, really good. And your special for today, are you having your special
No, feijoada, hoy no hay feijoada. Porque
no hay feijoada.
Hoy no.
Okay.
Hoy hay todos los platos, las carnes, fish, meat, pastas, pizzas, order por teléfono, pode ordenar por telefone, chamar por WhatsApp, ou entrar também direto na página website, hay un link.
Okay, there's a
Yes,
link
about the
on the
yeah.
website and on Facebook. And I believe Jessica's clinic also has a Facebook
Tiene
page. Fisioterapia,
Barcelona
clínica
contra
de
el Napoli
clínica de
y
fisioterapia. So both of them
primero.
it's in their Facebook pages, and you can find them on Facebook. This weekend, nobody can go out. We're all stuck at home. If you don't feel like cooking,
Doctora,
yeah.
Hoy, today, there is a very important soccer game. A la 1 de la tarde juega Barcelona. Barcelona plays today at 1 o'clock. A perfect day for a pizza.
A perfect day for a
Exacto.
pizza.
¿Contra quién juega?
Barcelona contra el Napoli y el Bayern contra el Chelsea.
Barcelona, Napoli. Barcelona, Napoli, and the other
Yes.
game is
Bayern contra el Chelsea.
okay, Chelsea contra el Bayern de Múnich.
Bayern Múnich.
Okay, el campeón alemán. A 1 o'clock, cable onda. Así que una ocasión perfecta para comerse una pizza, una lasaña, unos
No tiene que
espaguetis.
cocinar,
exacto.
Tiene que salir de
Y-
su casa, no puede salir de su casa.
Tremendo juego, Barcelona-Napoli. ¿Eh?
Ya ayer perdió el Real Madrid,
Sí,
quedó fuera de
ya me
la
pide en
Champions.
su
Sí,
casa,
yo sé.
6546-5663, 655663, 6546-5646-565663.
Or look on the Facebook page. Your phone number is on
Exacto,
Facebook page? Okay.
exacto. Y hoy tenemos un postre especial, un postre muy
Brigadeiro.
común en Brasil, que às
tan
vezes
bueno, tan bueno,
ahora é
brigadeiro.
época, é tempo
Sí,
de
sí.
maíz nuevo. Então, em Brasil temos um postre que hacemos com maíz nuevo.
Okay.
É como um manjar de maíz nuevo. Chamamos curau de milho verde, ou mingau de milho verde. E acá hoje temos, e é muito rico, o postre hecho com maíz verde,
there's a
leite
special
condensada,
Brazilian-
muito rico.
There's a special Brazilian dessert available
En tu
today.
casa
It's
cocinan
made from sweet
diferente a
corn
los,
and
a
condensed
los
milk.
restaurantes.
Como crema-
O sea, hacen
crema de
arroz
maíz.
y-
It's like a
Sí,
cream
nosotros
of
sí,
corn
sí, sí.
type of
Ella
dessert.
no te come
and
nada de
it sounds
pasta ni
delicious.
Sí,
pizza.
muy rico.
Dice
So
que está
order your
aquí.
pizza or your
Sí, sí, en la
pasta,
casa igual.
watch the soccer
Muy
game
raro
at
que no
1
comamos
p.m.
hamburguesas.
and
¿Verdad?
get your dessert
Yo
too.
preparamos
And it's
otra
all
cosa.
¿Quién
delivered
cocina tu mamá?
Mi
hot brought
papá,
to your door.
nuevamente, papá.
They take all the precautions
Él le gusta, ¿no?
necessary to
Sí,
prevent
sí, sí,
any.
Hoy solo delivery. Hoy mañana solo delivery.
Today and tomorrow only delivery. Obviously, we can't go out. So get your pizza, get your pasta, watch the game, or just relax
Leches.
on your patio.
Dedito de pescado, dedito de pollo con papas.
Chicken fingers, fish fingers, chicken with potatoes,
Lasañas,
lasagnas,
ravioles,
raviolis.
espaguetis,
So order,
fettuccines.
so order your dish. Okay, so this has been talking with your doctor here on Radio Chiriquí 103.3 from 10 a.m. to 11 a.m. I'd like to thank my guests, Jessica Bell and Dr. William Tour, for speaking today. Hope everybody has a lovely
Ese es el
day
micrófono que más
and
molesta,
a lovely
el de allá.
weekend. Stay home, wear your mask.
Mira que lo cerré y... Thank you.
Thank you.
Pablo.